Hello friends, welcome again to the last unit, that is of your Pharmacology-II course BP 503T. In our earlier lecture, we talked about the pharmacology of androgen and anabolic steroids. In this lecture number 39, we will be focusing on the pharmacology of estrogen. So let us start. I am Dr. Monica Sachdeva, Principal and Professor working at Department of Pharmacy, Rajkumar Goyal Institute of Technology. This presentation will take you through the classification of various estrogens, how these effects of estrogens are produced, what are the various pharmacological actions, their adverse effects and their uses, and we will also talk about the SERMs and the antiestrogens. So let us start. Now, in our earlier lecture, we talked about the male sex hormone, which was androgens, or the major was the testosterone. In this lecture, we will talk about the female sex hormone, which are the estrogens and the progesterones. This lecture will mainly focus on one of the hormone, that is the estrogen. Now, estrogen, this is a female sex hormone. Again, like we classified in the earlier case also, these estrogen, they can also be classified as natural ones and the synthetic ones. The natural estrogen, this is the estradiol, and this is the major hormone which is secreted by the ovary. Now, this estradiol, where are they synthesized? They are synthesized in the Graafian follicle, the corpus luteum, and also in the placenta in the females, and the starting material remains the same as we saw earlier, which is the cholesterol. And also we again saw that the testosterone, it is also responsible for conversion of testosterone into estradiol by the aromatase enzyme. Then this estradiol, this is oxidized in liver to produce another hormone, and other important estrogen, which is estrone, and this estrone this is hydroxylated and produces another hormone, another estrogen, which is the estriol. So we have three natural estrogens. They are estradiol, estrone and estrol, and the estriol. And all of these three estrogens, they are active, they circulate in the blood, but this estradiol estrogen, or the natural estrogen, it is the most potent estrogen. So we will be focusing on these drugs. Then we have certain synthetic estrogens also. Now, these natural estrogens, they are inactive orally. Why inactive orally? Because of their high first pass metabolism. Then they have very short duration of action, again due to rapid metabolism. So to overcome this disadvantage, certain steroidal and non-steroidal synthetic estrogens were developed. So the most important steroidal estrogens, they are ethinyl estradiol, they are mestranol, and they are tibolol. Then we have non-steroidal ones, which are diethyl stilbestrol, or generally called as stilbestrol. Then other drugs are hexastrol, dienestrol. So we have steroidal and we have non-steroidal synthetic estrogens. Now we will talk about that how these estrogens, the secretion of these estrogens are secreted. Now, since in females, this is a female sex hormone, and it depends upon the menstrual cycle. So at different phases of menstrual cycle, different amount of estrogen is increased or decreased. So we will talk about how these are released. So, if we see that again the hypothalamus that releases the gonadotropin releasing hormone stimulates the pituitary, pituitary releases FSH or LH, follicle stimulating hormone or the luteinizing hormone, and that acts upon the ovary and leads to the maturation, where it leads to production of progesterone and estrogen, which acts on the various reproductive tract and other tissues. Now, how does this this amount varies at different phases of the menstrual cycle? Now, the daily secretion of estrogens in the menstruating women, it ranges from about 10 to 100 micrograms, and that depends upon the phase of the menstrual cycle. Now, the secretion, it starts from the Graafian follicle under the influence of follicle stimulating hormone. After ovulation, that ovulation means when the ova is released, this corpus luteum, it continues to secrete estrogen till about 2 days before the menstruation. And estrogens, they exercise feedback inhibition by the direct action of, you can see here, direct action on the pituitary as well as on the hypothalamus. So, when there is increase in the level of the estrogen, they can the negative feedback can go through the interior pituitary as well as through the hypothalamus. And during pregnancy, if the implantation occurs, if pregnancy occurs, then the placenta, it secretes large amount of estrogen, and then during pregnancy the amount can increase up to 30 milligram per day at term. At term is at the time of the delivery, and as soon as the parturition or the birth of a baby takes place, then the level it declines. And also in the postmenopausal women, the daily production, it falls to around 2 to 10 micrograms. Now, what are the pharmacological actions of estrogen? Again, I will repeat that estradiol is the major estrogen, the natural estrogen, the most potent one. Now, these sex organs, the major action is on sex organs, responsible for all the pubertal changes which occur during the during puberty in girls, that is growth of uterus, the growth of fallopian tubes, and also growth of vagina. Then in case of absence of progesterone, or we also called as anovulatory cycles, it can lead to withdrawal of menstruation. Then it also facilitates the penetration by the sperm. How it this action is caused? It increases the rhythmic contractions of the fallopian tube and the uterus. It induces a watery secretion from the cervix, and thus it facilitates the penetration by the sperm. Then if the estrogens are deficient, it can lead to various atrophic changes in the female reproductive tract. Then it is also responsible for the production of certain secondary sex characteristics, like it proliferates the ducts of the mammary gland, causes accumulation of fat, then various axillary hair appear, and other behaviors are also affected by these estrogens during puberty. Then there are certain metabolic changes also, certain metabolic effects also which are seen by these estrogens. Estrogens, they are again anabolic, but their action is very weaker as compared to testosterone. And we saw that in ovary, it also secretes small amount of testosterone. So certain factors, certain increase in the growth that can also be during puberty, that can also be brought about by the testosterone. So these estrogens, they have the mineralocorticoid action. Mineralocorticoid action means that they cause retention of salt and water. In certain cases, long-term use can lead to edema. Then they also increase the plasma concentration of HDL, that is high density lipoproteins, and this is a beneficial effect, and it contributes to the low risk of atheromatous diseases which occur in the postmenopausal women. It also increases coagulability of the blood, thereby increasing the risk of thromboembolism. But this effect is dose related. As you increase the dose, as you take it for a longer period of time, this effect, increased coagulability of the blood, can occur. Then certain other pharmacological actions attributed to this estrogen, they are on the bone. Now this estrogens, they are important for maintaining the bone mass. How they maintain the bone mass? That is by retarding the bone resorption. They retard the bone resorption, and thus they maintain the bone mass. Then they also reduce the maturation and activity of osteoclasts, and thus they maintain the positive calcium balance. So that is how they have a positive, the bone mass is maintained by the on the bones. Now what is their mechanism of action? Again, these estrogens, they exert their actions through the receptors, which we call as estrogen receptors. Now again, the same class of family of the receptors as we talked about the testosterone. They bound to SHBC. Estrogen, they diffuse into the plasma membrane, binds to this estrogen receptor in the cytosol. Again, they undergo the conformational change, form the dimers. These dimers, they translocate into the nucleus and bind to the promoters, which are called as the estrogen receptor elements, and these elements, they then lead to the transcription through various cofactors, and the gene expression is then modulated, and this is how the action of these estrogens, it is produced. Now there are two distinct types of estrogen receptors. These are estrogen receptor alpha and they are estrogen receptor beta. So this estrogen receptor alpha, it predominates in the uterus, in vagina, bone, hypothalamus and blood vessels, and the estrogen receptor beta, it predominates in the prostate glands of the males and in the ovaries in the females. So all the actions which we saw, which are produced, if it is in uterus, vagina, bone, hypothalamus or the blood vessels, they are expressed through estrogen receptor alpha. And estradiol, it binds to both the receptors with equal affinity. We know that in males also, since it is expressed in the prostate glands, and testosterone is also, it is also converted into estradiol. So this estradiol, it has equal affinity for both the receptors, estrogen receptor alpha as well as beta. Now coming to the kinetic properties of estrogen, that is how the drugs are absorbed, distributed, metabolized and excreted. So these estrogens, not the natural ones, other just synthetic drugs, and they are well absorbed orally as well as transdermally, whereas these natural estrogens, they cannot be given orally. Why? Because they are inactivated due to the rapid first pass metabolism. And all these drugs, natural estrogens, we saw that they are bound to the plasma proteins. Then these estradiol, it is converted to estrone. We see that estrone is converted into estriol, and these drugs, they undergo both phase 1 reaction by glucuronic acid, and they also undergo sulfation reactions. And finally, they are excreted in urine. They may undergo enterohepatic circulation and are excreted in bile. Now, what are the uses of these estrogens? Now, the main use of these estrogens are that they are used in a hormone replacement therapy. Now, when this hormone replacement therapy is required, we know that at menopause, the females, when they undergo menopause, that is the stoppage of their menstrual cycle, there is a cessation of the ovarian function, and at that time the women, she suffers from a various number of physical consequences, various psychological and various emotional consequences. So this estrogen or the hormone replacement therapy, in short we call it as HRT, it suppresses all those pre-menopausal syndromes like hot flashes which occur due to the vasodilation. They also prevent the atrophic changes and the osteoporosis. We saw that in the pharmacological actions, we saw that it is responsible for maintaining the bone mass, responsible for the calcium balance. So when there is decrease in the estrogen level, it may lead to the osteoporosis. So this HRT, by giving estrogen as hormone replacement therapy, all these premenopausal or menopausal symptoms, they are suppressed. Then the drugs, they are also used in primary ovarian failure, like in case of Turner syndrome, where the ovary is not developed, the estrogen is not released, the female sex hormones are not released. In those cases, estrogens can be used. Then they are also used in case of severe cases of vaginitis. Vaginitis means inflammation of vagina. In that case also estrogens can be used so that the dryness of the vagina which occurs during vaginitis, that could be treated. Then they are also used as the contraception in various contraceptive pills. We will talk about it later on. And we also saw that it is also expressed in the prostate glands in the males, so it can also be used in the prostate cancer. Then certain adverse effects which are associated with estrogens, that can lead to tenderness in the breast, nausea, vomiting, because it has got mineralocorticoid action, so it can lead to retention of salt and water, which can lead to edema, and also the risk of thromboembolism. Then during postmenopausal replacement therapy, in certain women it can lead to menstruation like bleeding. Then it can also lead to endometrial hyperplasia, that is the endometrium, it increases. When if it is administered to males, excessive doses, it can lead to feminization, it can lead to development of breast in male, which is called as gynecomastia. Then estrogen administration to pregnant women, it can cause genital abnormalities in the offsprings. So that is why estrogens, they are totally contraindicated in pregnancy, that is, they should not be given in pregnancy. So that was all about the estrogens. We will now talk about the selective estrogen receptor modulators. In short, we call them as SERM. Again, these drugs also, they interact with the estrogen receptors, and depending upon which tissue type, they can have both the action, agonist action also, or they can have the antagonistic action. And the SERM, the drugs, they are tamoxifen, raloxifene and torimifene. What are the drugs? They are tamoxifen, raloxifene and torimifene. Now, what is this tamoxifen? Tamoxifen is a competitive antagonist to the estrogen at the receptors in the breast. Fine. So, they are antagonist to the estrogen receptors in the breast, and they are partial agonist at other estrogen receptors like bone, uterus or liver. So, they are generally used in the treatment of metastatic breast cancers in postmenopausal women, because it is being expressed in the breast. Toxicity is less, but the major side effect, it can lead to thromboembolism. Then another drug, raloxifene, it is an antagonist to estrogen receptor at endometrium, breast, and is a partial agonist in the bone as well as in the cardiovascular system. So, its use is based on its ability to decrease the bone resorption and the overall bone tumor. So, it leads to increase in bone density and is generally used for the treatment of osteoporosis in the postmenopausal women, because it is being expressed here in the bone. It is being used as a agonist. Then another drug, torimifene. It has again similar, all the effects are similar to that of tamoxifen, but it carries with it a risk of endometrial hyperplasia, and these cancer, they are not seen with this torimifene, and generally used with in case of postmenopausal women who have got metastatic breast cancer. Then another class of drugs is estrogen, it is anti-estrogen. Now, what do we mean by anti-estrogen? Anti-estrogen means that these drugs, they are the pure antagonist of estrogen receptors. In earlier SCRM we saw that the drugs, they could be either agonist or they could be antagonist. In certain tissues they act as agonist, in certain tissues they act as antagonist. But these drugs, anti-estrogens, they are pure antagonist of the estrogenic receptors in all the human tissues, and the drug is called as the clomiphene. Now, how does this clomiphene act? Generally used as a clomiphene citrate. It competitively it blocks both the receptors, estrogen receptor alpha and also estrogen receptor beta, and it opposes or it abolishes the negative feedback mechanism effect of the androgen receptor. Okay, so all these जो negative feedback mechanism है, that is abolished. जब negative feedback नहीं होगा तो what will happen? There is stimulation of release of the gonads, that is the FSH and the LH, it increases, the hormones increases, and this induces the ovulation. So, that is how this anti-estrogen or clomiphene as anti-estrogenic drug it acts. It opposes the negative feedback mechanism and stimulates the secretion of FSH and LH and induces ovulation. So, as we can see from its mechanism of action, it is used in case of infertility. Infertility due to anovulation. Anovulation means when no ovulation is occurring, when the ova are not released. It can also be used in case of male infertility where there is oligozoospermia. Oligozoospermia means when there is less amount of sperms are produced. So, because it increases the secretion of FSH, it can promote spermatogenesis. Then it is also used along with gonadotropins to improve the maturation and harvesting of ova in case of infertilization IVF techniques. This clomiphene is one of the main drug which is used here. But the adverse effects which are associated with clomiphene, they are, it can lead to multiple pregnancies, It can lead to enlargement of ovaries, can lead to various cysts which are formed in the ovaries, or we call them as polycystic ovaries. It can lead to hot flushes, it can lead to weight gain, or it can lead to alopecia, or it can lead to vertigo. So that is about the clomiphene, which is an anti-estrogen drug and can be used in case of infertility in case of males as well as in females. So that was all about the pharmacology of estrogen, where we talked about the mechanism of action, the pharmacological actions, uses and adverse effects of estrogens, SERMs as well as antiestrogens. Thank you.